And for that, there are two chairpersons, one myself, Dr. Vipul Chavda from RIMS Ahmedabad, and my co-chair is Dr. Disang Patel, MD from Vadodara, from Glucowell Diabetic Center. So as we are running short of time, let's straightforward start our first talk, and our first speaker is none other than Dr. Narsingh Verma sir, who actually requires no introduction because he is a teacher and mentor for many doctors, including me. He's a MBBS, MD, FACP, FRCP from London as well as Edinburgh, FIMSA, FAMS, FICN, FIACM, and a fellow RSSDI. He is fellow of Diabetes India, professor and head of Department of Physiology, officiating head and Department of Family Medicine, former head Department of Transfusion Medicine, and Dean of Student Welfare, KGMU, Lucknow. His area of interest is chronobiology and metabolic disease. He has more than 225 original publications in peer-reviewed index journal and award. He has a 14 international and 38 national awards in the field of cardiovascular as well as metabolic disease. He is a life member of 14 international and 29 national scientific bodies, and he holds a very much prestigious position in various scientific bodies. So without wasting much time, let's start sir's talk. And sir is physically present here as well as he has given his recorded talk. So I will request RX team to start Dr. Narsingh Verma sir's talk. And if sir want to say something before the talk, we can have sir on air. Please start the talk.
First of all, I would like to thank the organizers of Diabetes India for inviting me and giving me this very important topic, that is understanding pathophysiology of glucagon in diabetes. And I would like to thank especially Dr. Bansi Sabu for giving me this opportunity to talk about the topic, which is very, very important and pertinent. I will be talking about glucagon. So first, in early 1920s, the Kimball and John Merlin identified pancreatic extracts, and he found that it is responsible for blood sugar increase rather than increase. And later on, it was termed as glucagon. Glucagon is a 29 amino acid peptide hormone, and it is a counter to insulin and stimulated hepatic glucose production. And also it increases plasma glucose level by both mechanisms, that is glycogenolysis and neoglucogenesis. Glucagon also stimulates ketogenesis, thus working in tandem with insulin to maintain a normal fuel balance. That is why probably nowadays we are talking more about glucagon because of this particular action. Insulin, we know, acts as a glucose depositing and anabolic hormone, and counter to that, glucagon is a glucose mobilizing and catabolic hormone if you compare with the insulin. Most important thing is that we know that beta cells are responsible for secretion of insulin and amylin, while the alpha cells are responsible for secretion of glucagon. We also know that at the time of birth, the beta cells are more in number, around 60% of this total cell of islet of Langerhans are beta cell, and the rest are, most of them are alpha cell, and very few belong to other varieties. So this insulin-glucagon ratio becomes very important because we know that both alpha and beta cells are formed by same precursor. That is why today's concept is that probably alpha and beta cell have same progenitor cell, so the alpha cell and beta cell are interconvertible. Insulin-glucagon molar ratio is more important rather than the beta and alpha cell ratio, because it is the ratio in plasma, it is more important than their individual concentration. So it may not be that important that how much insulin one is having and how much glucagon is having. Probably it is the ratio of insulin and glucagon is more important. Normally the IG ratio, which is called as insulin-glucagon ratio, following a balanced diet is approximately 3, meaning by that 3 is insulin and 1 is the glucagon. So following overnight fasting, it decreases to 1. So in normal person without any disease, the Ig ratio keeps on changing. It varies from 3 to 1. So after diet, it is maximum 3, and in fasting condition, it is 1. When person goes to prolonged fasting, more than 24 hours, or even more than that, the ratio may be as low as 0.4, because in that condition, hardly any insulin is secreted, only basal secretion of insulin is there, and glucagon keeps on increasing. Following glucose infusion, the ratio may rise up to 30. When glucose is given, then that stimulates insulin secretion, and this Ig ratio goes up to 30. In diabetes, inappropriate Ig ratio influences metabolic status. So, in other terms, in diabetes, we should also focus the Ig ratio, which is a very important factor. What is happening by glucagon? Glucagon secreted by the pro-glucagon molecule as a pro-hormone like the insulin, and it is converted into glucagon by pro-hormone convertase 2. And this pro-hormone convertase 2 is rarely deficient, so it is easily converting the glucagon into pro-glucagon into glucagon. By portal circulation, like the insulin, glucagon reaches to the liver first, and first receiving organ is the liver, similar to insulin. And this, in liver, it produces glycogenolysis, gluconeogenesis, fatty acid oxidation, and ketogenesis. These are the 4 important functions glucagon produces in the liver. And their order is also same. That is, first action is glycogenolysis. And we know that the liver glycogen, whichever store is there, is depleted within 12 to 15 hours, and now no glycogen is left in the liver. We also know that the muscle glycogen is only for that particular muscle, while the liver glycogen is for whole of the body. And this glycogenolysis produces more glucose, that is hepatic output of glucose. When glycogen stores are depleted, then gluconeogenesis starts, and fatty acid oxidation and ketogenesis follows. Epinephrine and other counter-regulatory hormones provide gluconeogenic precursors like lactate, amino acids, glycerol to liver for raising blood sugar. So they do have their function, but they will provide the gluconeogenic precursors like lactate, amino acid, glycerol, etc. But the main function is done by glucagon. So factors which regulate glucagon secretion are so many, and the secretion of glucagon is increased by hypoglycemia, and the carbohydrate and meal stress decreases the glucagon secretion. Protein meal increases glucagon secretion, while isolation decreases glucagon secretion. Most of the amino acids increase glucagon secretion, while non-esterified fatty acids decrease the glucagon secretion. Some fatty acids may also increase it, but ketones definitely decrease glucagon secretion. Parasympathetic nerves, when the parasympathetic stimulation is there, the glucagon secretion will be more, while the gamma-aminobutyric acid, GABA decreases glucagon secretion. Sympathetic nerves also increase glucagon secretion, while the ATPs decrease glucagon secretion. Whenever there are more ATPs already present, then the glucagon will be decreased. The pituitary adrenal cycloactivating polypeptide, this increases glucagon secretion, but the zinc decreases glucagon secretion. Cold exposure have been seen to increase glucagon secretion. So glucagon will be more in temperate countries in relation to tropical countries. Hormones which have the impact on glucagon secretion, the adrenaline or epinephrine increases glucagon secretion, and cholecystokinin increases glucagon secretion. Gastrin-releasing peptide ghrelin, GIP, oxytocin, vasoactive intestinal peptide, and vasopressin. They all increase glucagon secretion. And amylin, glucagon-like peptide, GLP-1, insulin, leptin, secretin, and somatostatin, they all decrease glucagon secretion. So this was the hormonal actions, various hormones which have action on the glucagon secretion. What is the mechanism of action of glucagon? Glucagon acts by the glucagon receptor, and you see the glucagon receptor serpentile structure, and this receptor, when the glucagon combines with this receptor, a lot of activities take place. And this is regulated by inositol and triphosphate INSP3 pathway, and that increases calcium ions, and that again is responsible for glycolysis, glycogenesis, gluconeogenesis, and increasing glucose. This is also potentiated by lot of activities, and again it is by adenyl cyclase, CMP pathway, and inside cytoplasm. It increases the pKa, and that increases PGC1 and the G6 phase, and is responsible for most of the action of glucagon, which are glycolysis, glycogenolysis, and the gluconeogenesis. The glycolysis and glycogenesis is decreased, while the glycogenolysis and gluconeogenesis increases. So that is responsible for hepatic output of glucose. This is the pancreatic islet structure, which facilitate pancreatic signaling. Because this structure is unique, you see exocrine pancreatic glands are outside, and they are acinar cells, and they secrete pancreatic juice, and they have no role in the endocrine role, and they are exocrine process. But we know that endo-exo connection do exist, and endocrine functions are affected by exocrine functions, and vice versa. The alpha cells, you say they are lined, related close to exocrine pancreas, and you see beta cells are little inner inside, delta cells are also inside, and you see that F cells are also there. So what happened that the various hormones, which are secreted by the same cell, they do have the action on the same cell, and we know this is called an autocrine effect. And when the beta cell secretes something, and which is having action on alpha cell, this is called as paracrine effect. So both paracrine and autocrine effects are responsible, meaning by that the release of glucagon has action on the alpha cell and vice versa. Similarly, the beta cell release, that is the release of the insulin and amylin, will have impact on the release of glucagon, and vice versa. That is, glucagon release will have impact on the amylin and insulin secretion. So we know that these paracrine, autocrine, neurocrine, endocrine, exocrine effects are responsible for most of the action which we see in a tandem manner. Centrifugal pattern of blood flow in pancreatic islet to facilitate paracrine regulation of blood glucose. This is possible by centrifugal pattern. Blood enters from center and drains outwards. So this blood flow pattern allows secreted hormones to regulate other cells within the islet. This is possible by centrifugal pattern. You see here the regulation of blood glucose by insulin and glucagon in a healthy individual is possible. That is in hyperglycemic condition. Pancreatic cells, beta cell release insulin, and these insulin stimulate glucose uptake by cells, and they also produce glycogen synthesis in liver. And in the liver and the other cells, including the fat cells, the plasma glucose return to normal levels because the muscles now can utilize glucose. The adipose tissue can synthesize more fat, and the glucose can synthesize more glycogen in presence of insulin. So blood glucose returns to normal. And then what happens in the fasting condition, or when the person is developing hypoglycemia, then alpha cell secretes glucagon, and this glucagon produces glycogenolysis, and it also inhibits the glucolysis, and the neoglucogenesis do occur, and that maintains plasma blood glucose to normal level, and this is the action of the glucagon. Alpha cell glucagon secretion dependent on beta cell insulin secretion that I have already talked about, and pathophysiology type 1 and advanced type 2 diabetes happens that when there is no insulin, so glucagon increases, and when even insulin is there, then the glucagon increases. This is the special thing, and even after the fasting condition, glucagon secretion should go out, but even in prandial condition, glucagon continues to increase, and glucagon increase is one pathophysiology which is central in pathophysiologies of type 2 diabetes. We know that in type 2 diabetes, the more pathophysiologies are known, but this one pathophysiology, which is part and parcel of the ominous octet, that has shown that increased glucagon level is a very important pathophysiology. The aberrant secretion of glucagon resulting in elevated glucagon concentration in both the fasting state and after meal are important. In altered alpha to beta cell ratio may be a contributing factor in type 2 diabetes pathogenesis. The relative hyperglucogonemia of diabetes resulting from an altered alpha to beta cell ratio might be a consequence of beta cell dedifferentiation to glucagon producing islet cell, which I talked earlier that both cells are from same progenitor cell, and due to that more alpha cells are being formed, and that is evident that after 10 years of type 2 diabetes, the alpha cell increase in the number and the beta cell goes down, and the condition reverse. Now 60% of the islet of Langerhans are alpha cell and only 40% beta cell. Glucagon also plays a role in lipid metabolism, influencing food intake, affects body weight, promotes autophagy, and has pleiotropic effect on the cardiovascular system. We know because of these pleiotropic effects, the glucagon is being discussed during these days, and we know that it has impact on lipid metabolism, food intake, and body weight. The high insulin, when we talk about insulin-glucagon interaction, the high insulin-glucagon ratio promotes biosynthesis of proteins, inhibits glucose production, and reduces release of free fatty acids. So, a low insulin-glucagon ratio helps the body access stored nutrients, increase hepatic glucose production from glycogen and amino acids, and promotes the breakdown of adipose tissue into free fatty acid and glycerol. It is called as the physiological fulcrum. This insulin-glucagon interaction is called as a physiological fulcrum, balancing the two opposite ends of the metabolic spectrum to conserve energy if possible, but provide it when needed. So both are required. Sometimes we need that energy should be conserved, and sometimes we need the energy should be provided. So that is possible only by flipping off the switch and making the insulin-glucagon interaction in a different ways. Now I will talk about effect of various drugs on the glucagon levels. You see, we are using a lot of OHAs in the type 2 diabetes management, and metformin also acts by inhibition of glucagon, induced stimulation of gluconeogenesis. So one of the action of metformin is by inhibiting glucagon, which we are achieving by GLP-1. So the combination of GLP-1 RA drugs with metformin can be a synergistic combination because both will have synergism. Metformin also acts to antagonize glucagon by affecting the cyclic exogenous insulin and was shown to decrease plasma glucagon levels in the patient with type 2 diabetes. So it was seen that metformin has two actions which are in favor with the management of type 2 diabetes involving glucagon. Exogenous insulin was shown to decrease plasma glucagon levels in patients with type 2 diabetes. So that is why the exogenous insulin is somehow helpful in decreasing the plasma glucagon levels. Sulfonylurea and pioglitazone have not been shown having any potential effect on glucagon levels. Experimentally, few studies have shown, but finally, we have not found enough studies which can claim that glucagon levels are affected by sulfonylurea and pioglitazone. Amylin mimetic decrease postprandial glucagon levels. We don't have these drugs in my country, but those drugs which countries are having the drug did decrease postprandial glucagon levels, similar having the paracrine effect. The GLP-1 RA DB4 inhibitors decrease postprandial glucagon levels thus increase insulin glucagon ratio, and that is why they are helpful and in the management of type 2 diabetes. SGLT2 inhibitors produce increased fasting glucagon and postprandial glucagon levels and decrease insulin glucagon ratio. That is one thing which is being discussed with SGLT2 inhibitors, and that is why when we combine SGLT2 inhibitors with DP4 inhibitors, then we say that probably this action is negated by DP4 inhibitors. Glucagon in hypoglycemia and hyperglycemia in diabetes. Type 1 and advanced type 2 diabetes mellitus, there is beta cell failure, and that is responsible for absolute endogenous insulin deficiency. And when there is absolute endogenous insulin deficiency, abnormal glucagon secretion is involved in pathogenesis of both hypoglycemia and hyperglycemia in diabetes. So glucagon behaves differently when insulin is available and when it is not available. Relevance of glucagon to hyperglycemia in diabetes, finally leading to DKA. Insulin deficiency, infections like pneumonia, UTI, cellulitis, inflammations like pancreatitis, cholecystitis, intoxications like alcohol, cocaine, infarctions, acute MI, CVA, iatrogenic corticosteroid surgery. These 6 I are responsible to produce these conditions, and where the demand of insulin increases, and here the glucagon becomes very important and in the prevalence of the DKA. The role of insulin and a counter-regulatory hormone like glucagon in pathogenesis of DKA. When insulin is decreased, free fatty acids rise, acetyl coenzyme may rise, ketone bodies rise, and these ketone bodies we know glucose is also increased. They produce hyperkalemia, hyperosmolar condition, and acidosis. And the ketone bodies are responsible for at least 2 symptoms. They are vomiting and kusumal breathing, which is pathognomy of DKA. Another story coming there is increased stress levels, and when the sympathetic nervous system is not responding to that, and catecholamine levels and glucagon rise, and the glycogenolysis occurs, gluconeogenesis from amino acid, lactic acid, glycerol, and increased glucose levels are seen, and the osmotic diuresis is there, and that is producing dehydration. So all the 3 dehydration, ketone bodies rise, hyperkalemia, hyperosmolar condition, acidosis are explained by this interaction of glucagon insulin. So when glucose level goes down, the pancreatic islets, beta cell failure, there is decreased insulin, and alpha cell secrete more glucagon, and the glucagon is more, and it prevents hypoglycemia. So in conclusion, we can say that glucagon dysregulation contributes substantially to the pathophysiology of diabetes, and utilizing hypoglycemic therapies which target glucagon can help improve glycemic control. Certain agents currently used to treat diabetes may exert some of their hypoglycemic effects by restraining glucagon secretion or inhibiting glucagon action. For example, mechanism of metformin may involve inhibiting glucagon signaling in hepatocytes, whereas GLP-1 receptor agonists and DP4 inhibitors have been shown to reduce glucagon excursions in patients with diabetes. Optimizing diabetes therapy in the future will require skill targeting of alpha cell dysfunction, balanced with insulin replacement therapy. So that will be the crux of knowing glucagon better. Thank you. Thank you very much. These were my references. Thank you. Thank you. Thank you very much.
It was indeed interesting as well as a useful talk, sir, and we always learn something from you. Insulin is a main thing in the management and pathophysiology of diabetes, but glucagon is equally important, and we have to look into the pathophysiology of glucagon to understand the pathophysiology and acute and chronic complications of diabetics. Thank you so much, sir. Sir, would you like to make any comment right now?
I think you have already said that it is the high time that we should be not only targeting the beta cell, we should also think about alpha cell. And it is the synergistic effect of beta and alpha cell, which is responsible for normal glucose and lipid metabolism. That is why newer and newer therapies are targeting alpha cell function as well.
Thank you, sir. So now I would like Dr. Disang to introduce our next speaker.
Thank you very much, Dr. Vipul. So with this wonderful lecture, now I am inviting our next speaker, Dr. Adi Mehta. He is a faculty and he is attending staff of Endocrine and Metabolic Institute, Cleveland Clinic from 1993 to present. He is also the Associate Professor of Department of Endocrinology and Internal Medicine since 1982 to 1993. And he is a member of American Association of Clinical Endocrinologists, the Endocrine Society, and the American Diabetic Association. With this short introduction, I would like to invite Dr. Adi Mehta for his session. He is going to speak on halting the progression of chronic kidney disease, a myth or reality.
Alex team, we have recorded video, or sir is going to present?
No, sir, it's a live session.
Okay. Dr. Mehta, sir, you are not visible as well as audible. There is some technical glitch, I guess. Can we have any contact with him from RX team?
Yes, sir. So I messaged to.
Yeah.
Okay.
Yeah, he is no.
I think he's there.
Yes, sir.
Hello, Dr. Adi Mehta. Am I audible to you? I think he's not.
Yeah, he is not responding. There is some technical or internet glitch there. So until he gets his connection, can we move to the next talk? Because Dr. Sen is also here.
Yeah. RX team, can you confirm? Can we move toward next talk?
Okay, sir.
Okay, so
Please give the introductory slide of Mr. Sen.
Yeah.
Yeah, Dr. Desang, please introduce.
Thank you. So because of the technical glitch from Dr. Adi Mehta, now we are moving ahead toward the next session taken by Dr. Sachi Sen. He is the professor of medicine from the George Washington University with a demonstrated history of working in the higher education industry. He is skilled in the clinical research, medical education. He has a strong professional graduated from the Royal College of Physicians in UK and Ireland. He is basically graduated from the India, and after that he has moved to UK, and he's certified by the RCP London as MRCP, and he has also many awards and fellowship in his name. He is also the fellowship of endocrinology from 2005 to 2009. He is also the faculty of Tufts University assistant professor till 2013. So with this brief introduction, I think I would like to invite Dr. Sachi Sen. He is going to speak on precision medicine, a hype or hope.
Thank you. I hope all of you can hear me.
Yes, sir. You are clearly visible and audible.
Awesome. Let me try to share my slides. You can see my slide, I hope, right?
Yeah, it's visible, sir. You can go ahead.
Okay. So thank you for inviting me to give this talk. I know my introduction slide looked very busy, but basically I'm a professor at George Washington University in Washington, DC, and I work on stem cells and precision medicine in diabetes. So without further ado, so essentially we are going to talk about how we can use a prediction model for clinical decision making using gut microbiome. So precision medicine is essentially when a person, for example, is fairly new, but for an example, a person, let's say, needs a blood transfusion and he is trying to match the blood type to the recipient to reduce the risk of complications. So in other words, how can we predict a transfusion that is not going to go wrong and just catered to an individual person, and what would work best for that particular person? And right now, our medicine is not so-called geared towards an individual person. It's based on large data sets, which does not always preclude to a singular person and their disease, mortality, and morbidity. So essentially, the prime components of precision medicine right now is how does lifestyle and environment influence a person's disease. So that's why it's important as a so-called preventive medicine step. So the goals of precision medicine are to predict, prevent, and treat a disease. And it's actually very important for a metabolic disease, which, as you know, goes on for a significant period of time and then manifests at a later stage. For example, diabetes is we call the iceberg phenomena, right? So precision medicine is an emerging approach to a disease treatment, including various components such as the genes, environment, and lifestyle of each person. So it actually is beyond what we call just genes or epigenetics. It also includes lifestyle and, for example, diet, exercise, etc. So here is a schema which talks about how we integrate all these different information pieces. So we have information inflow coming from direct volunteers, and then we integrate their data into a data set, right? And then we upload it to a cloud with the identification taken out. And we try to get all the data from different biological samples in order to also have influence from the clinicians and then get an output from the information flow out. Now, I know this is not very clear right now, but let me explain a bit more. So the various data sources at the moment we have is a self-reported measures such as diet, activity, so on. Then you have the vitals that you would get done in a physician's office. And then comes the so-called coding of various diseases that a person has. So that, and that's why coding for a particular disease is so very important. And now every healthcare system in the United States would insist about appropriate coding, because that's how you build a data set. Then comes the so-called different biospecimens, for example, blood, fat, stem cells from blood and fat, and ultimately stool microbiome, right? So you have to, if you think about it, you have to identify which is your primary outcome and where do you put your most of your statistical prediction on. So if you talk about genes, epigenetics or environment, and one's lifestyle, this stool microbiome almost involves all these components or has a reflection from all these components. So this has been talked about, precision medicine, way back in our meeting at Diabetes. or ADA in 2020, when it was talked about as precision diagnostics. In other words, taking into epidemiological evaluation, probability, and diagnostic testing. So precision diagnostics is number 1 point. I'm just introducing some terms right now. Then comes the precision therapeutics. In other words, you take into account what interventions can you possibly do. Let's say prediabetes, which, as you know, in the United States, we have 80 million people with prediabetes, and I'm sure, which is about 1/4 of the population. And I'm sure the statistics won't be that different in India either. So you have various therapeutic interventions, starting from lifestyle to therapy. And then you have prognostics, which includes various complications of the disease, such as cerebrovascular retinopathy, cardiovascular, and so on. So you have to actually integrate, as you have been listening to different talks, that what medications work for different complications. And clearly, there's not a singular answer to that. In certain conditions, such as nephropathy, SGLT2 may be better. In cardiovascular, you might have a GLP-1 working better, but how to integrate one person's lifestyle, food items, to all of these interventions? So as you can imagine, it's a huge data set that we have to integrate to individualize and decide what medication would work for that particular person. So the path to precision diabetes medication involves a lot of data collection and integration. And then ideally, it should have a format where a clinician can input these data and get a science-based prediction. Right now, as a clinician, when all of us sit in front of a patient, it's based on certain parameters of large-set clinical trials, which may not have anything to do with that particular person sitting in front of you. So we need so it almost becomes an eeny, meeny, miny, mo business. So instead of that, you need some form of science, and that's what the precision medicine or prediction medicine is trying to do, to individualize therapy. So here comes the gut microbiome. Why do we think gut microbiome may be a novel diagnostic tool towards precision medicine? Because the gut microbiome essentially is a collection of various organisms in the ecosystem, right? It's a collection of genes in the microbiomes and influences from the environment, meaning influence from the diet, from the lifestyle, and so on. So it has certain components, particularly metagenomics, which is the genomics part of the microbiome. To that, you can add so-called metabolomics, which you can get from the, let's say, serum, right? So essentially, you are trying to integrate metagenomics, transcriptomics, and metabolomics. I know these words are bombastic, but let's kind of bring it down to so-called genomics from a stool flora, metabolomics from serum, and you're trying to integrate all of this along with the history of the patient. So the gut microbiome, environment and host interaction is actually important, and we have recognized this several decades back. But the microbiome is the primary filter for a large environmental exposure such as food, right? So essentially, we are what we eat. It's the largest endocrine organ, which is the gut, and possibly the most efficient metabolic machinery. It generates various useful metabolites, also toxic products, which are detoxified by the bacteria in a physiological state. So it's in a constant flux. In fact, it's every day that flux or the biome changes based on what you have done or what you're about to eat. So the gut microbiome and the health, it integrates, it controls the digestive function, it generates the metabolic products, degrades dietary oxalates, and so on and so forth. And of course, it has an influence on your drug metabolism. So as So all of these, if you think about it, is way more individualized than what you can get from serum or urine per se. So this was actually recognized by our predecessors in medicine way back in before Christ, that the death sits in the bowels and bad digestion is the root of all evils. So it's essentially revisiting what we knew for 2000 years. Qualitative and quantitative changes in the gut flora and its distribution would change, and gut dysbiosis is actually an important topic. So why dysbiosis in metabolic disease? It has an influence on the gut from various components. I'm not going to talk of individually all of this, but I think all of you know most of this to begin with. So let's talk about very basic topics, for example, that is already in textbooks right now. So some of the endocrinologists in the United States have certified in so-called obesity medicine. As you know, this is primarily a diet-based issue along with lifestyle. So this is almost part and parcel of that course, which means if you have a higher ratio of firmicutes to bacteroides, your chance of getting cardiovascular disease is way higher. So this is something we know. And this took us several years to consolidate this data, right? So how can we build on this very simple data that we have here to better prediction to, let's say, a particular diet, such as Mediterranean diet, ketogenic diet, and so on and so forth. We also know about from 10 years back that various items, for example, red meat, carnitine, etc., promotes atherosclerosis. Now, this wasn't actually linked to firmicutes and bacteroides, but it actually was linked to certain flora within the gut, right? Then we also have so-called microbiome therapy, where we can treat a specific microbiome and restore the dysfunction. So, such as prebiotics are non-digestible food items that are used to restore a particular flora, which can subsequently change your metabolism. And then we have so-called microbiome engineering, where you have a signal transduction from an environment, signal, then you propagate that, and you can engineer a specific microbiome to improve your metabolic health per se. So let's come to our study, what we are trying to do, because I don't want to take you too further into microbiome, which is a whole different topic itself. I'm sure somebody has covered it in these sessions. But what we are trying to do is to try to identify what lifestyle would work for veterans. So this is a US federal government mandated study. We have, as you know, a significant amount of patients, 88 million Americans have prediabetes. And how can we predict whether a certain food item, for example, low-calorie ketogenic diet, can change the gut microbiome, and is it even worthwhile for certain number of people? So what we plan to do is to use a machine learning database application and to discern signals from the gut microbiome, utilizing gut genomics, serum metabolomics, and even urine microbiomes and urine flora. And we are going to target primarily A1C of 5.7 to 6.4, because diabetes prevention program and other studies have shown that lifestyle changes do help. But obviously not everybody. And that's why we are trying to individualize who would benefit. And as you can imagine, when a patient walks in with prediabetes, we often tell them, go and do lifestyle intervention. But that means they have lost 2 years of their life in this process. And then the next time they come to you, if they haven't responded, they're full-fledged diabetic. or very close to it. So you have actually lost not only time, but their precious health. And this goes on and on. It doesn't just stop from prediabetes to diabetes. It goes on even when they have diabetes. So our secondary objective is to corroborate all these data from gut microbiome along with other studies that we know have been shown to have strong biomarkers such as serum-based, serum endothelial inflammatory markers, appetite-controlling hormones, renal function, and so on. So as you can imagine, all these are linked, but we have not yet developed a database which is primarily based on pre-diabetes subjects. And our study hypothesis essentially is to use the gut microbiome and the metadata used from this study with a short intervention of 3 months to see what changes in a short ketogenic intervention, diet intervention. Now, ketogenic diet is actually interesting in the sense that within 1 month, it can change the gut microbiome. So 3 months actually is quite enough to show those changes. So we are going to put it in a database that we have developed along with the federal government. This has several $1 billion have gone into it. And our aim is to ultimately apply this predict mode machine for clinical use. And our projected time is about 3 years down the road. So we have a clinician like me with a lab along with bioinformatics, which is also from one of my colleagues at GW, who is Dr. Mazumdar, who is actually a graduate from Calcutta as well, but he has done significant amount of work on database development in medicine. As I said, we are going to develop these various steps. I'm not going to read through it, but our future considerations is to go into not just prediabetes, but other disease models as well. We have already published some data on COVID and projection of COVID from our databases. So we are also trying to identify the appropriate patients, not just veterans, but beyond veterans, getting the fetal microbiome data, statistics, and response. The good thing about why this is based in the VA system is because the VA system is integrated throughout the country. And we have data from all the VAs across the 50 states. So that's why the statistics is actually enormous on all these patients. There's obviously a huge amount of advantage in using the database that we have along with the microgenomics that we're going to apply. And of course, as I said, the potential is quite large going forward. So in summary, we have a human host and gut microbiome that is interdependent. It's inflammation-based and CVD-based. We have already some data on it. And in summary, we would like to emphasize that utilizing the gut microbiome metagenomics along with the metabolomics to develop a prediction model to determine how an intervention as simple as ketogenic diet can be effective without wasting time, fund, and metabolic health. Thank you so much. And these are my fundings, my group, and I'm happy to take any question. And I've tried to keep it within the time limit.
Yeah, definitely, sir. You have finished on time. And first of all, thank you very much for such a wonderful session on the precision medicine. And I would like to congratulate you for such a wonderful study that you are carrying out in this area. And definitely, we would like to know the results in the future, that how it can help to predict the persons who will be helpful for the ketogenic diet. And I'm sure that many more studies may be coming in the future in this regard in the precision medicine. Because we are running short of time, I think I'd like to keep the discussion at the end. And now I would like to invite Dr. Adi Mehta to carry his session. Sir, first of all, we are very much sorry that we have to keep your session last because of the technical glitch. And now I officially invite you for your session. You are going to talk on the halting the progression of chronic kidney disease, myth or reality. Sir, please.
RX team, please share the
Not,
interesting slide
you are not
number 4.
audible, sir. Your voice is not coming. RX team, can you help Dr. Adi Mehta? Because I can see the unmute symbol is there on his screen, but still his voice is not coming.
Yes, sir. Now you are visible. Sir, your voice is not
Sir.
coming.
Hello. Sir, there is a left side in below button, mute, and in these, the sentence is same as system microphone. So please click on this. Yeah. Hello. You're not audible, sir.
I think sir has not joined using the Wi-Fi or cellular data. Audio is not joined. He's just present with the video. Can anybody call him from RX team?
Yes, sure.
Sir is showing some numbers on the screen.